Welcome back to The Explainer. Today, we're decoding something incredibly fascinating, Hirschsprung disease. You know, the human gut actually has its own independent nervous system. We often call it our second brain. But what happens when a newborn is fundamentally missing that internal communication system? Well, let's map it out.
Okay, let's dive into this by picturing a severe physiological traffic jam right at the start of a newborn's life. It's a serious medical mystery. Think about it. 99% of term infants will pass their very first stool, called meconium, within the first 48 hours of life. When a baby doesn't, that instantly raises a massive red flag for clinicians. The big question is, are we just looking at a minor delay, or is it a mechanical obstruction? In the case of Hirschsprung disease, we're dealing with a profoundly structural roadblock.
To solve this mystery, our explainer is going to follow a really clear briefing structure today. 1. Pathophysiology. 2. Diagnostics. 3. Treatment. And 4. Complications.
All right, kicking things off with Section 1, pathophysiology and those missing ganglion cells.
Now, check out the stark visual contrast here between the upper and lower parts of the bow. You've got this massively backed up, distended colon sitting right on top of a completely narrowed, pinched-off section leading down to the rectum. But here's the wild part. That narrowed section isn't actually clamping down on purpose. It's the aganglionic portion. It's acting like a physical barrier simply because it entirely lacks the ability to move things forward, which directly causes that massive backlog you're seeing above it.
So why the pinch? Well, looking at the formal medical term kind of gives it away. Congenital aganglionic megacolon. The core defect here is the absolute absence of ganglion cells in two very specific networks, the myenteric plexus of Auerbach and the submucosal plexus of Meissner. Without these crucial little cells, the gut's entire communication network is just down. There are zero nerve signals telling the highway traffic to keep moving.
And this leads to a total mechanical failure. We're talking about the complete loss of the rectosphincteric reflex. Normally, when stool enters the rectum, the internal sphincter just automatically relaxes to let it out, right? But in Hirschsprung disease, that internal sphincter simply does not relax. Because the enteric nervous system isn't stimulating the bowel like it should, there's an unopposed sympathetic stimulation. This actively cranks up the intestinal tone, clamps the sphincter completely shut, and literally halts peristalsis right in its tracks.
So a huge question is, just how much of the highway is actually missing its traffic signals? The data shows us that 80% of cases are what we call short segment disease, meaning this aganglionic section is restricted to just the rectum and the distal colon. About 15% have long segment disease, which can involve the entire colon or even parts of the small intestine. And in about 5% of cases, we see total intestinal aganglionosis, where the whole gut is missing those vital cells.
Moving right along to Section 2, diagnostics. How do we actually spot this disease?
In the newborn period, the alarms sound fast. The absolute key indicator, like we mentioned, is a failure to pass meconium within that critical 24 to 48-hour window. But guys, this is not just a missing diaper change. This is rapidly accompanied by a total refusal to feed, an increasingly swollen, distended abdomen, and very concerning bilious or green vomiting. This triad of signs is a massive red flashing light pointing to a dangerous lower intestinal obstruction.
Now, what if the traffic jam isn't total? Maybe it's a super short segment. In that case, the child might get a bit older before anyone figures it out. In infancy and childhood, the clinical picture shifts a bit. You start seeing failure to thrive, visible peristalsis right through the belly, and a really chronic, severe pattern of constipation. Fascinatingly, because the stool literally has to squeeze past that tight, narrow roadblock, it often comes out as uniquely ribbon-like, incredibly foul-smelling stools. And on physical exam, the rectum will actually feel totally empty, but the clinician can easily feel a large backed-up fecal mass higher up in the abdomen.
Let's see how this builds into a formal diagnostic pathway. We don't just guess here, we follow a really logical sequence. Step 1 is clinical history and physical signs. Then, imaging like a contrast enema is used to visually prove that transition zone between the huge dilated proximal megacolon and that tiny, narrowed distal segment. From there, we move to functional pressure testing, and finally, tissue retrieval. Let's look closer at Step 3, anorectal manometry. This is a non-invasive test where a tiny catheter with a balloon is inserted into the rectum. The balloon is safely inflated to simulate stool entering that space. In a normal patient, this distension causes the internal sphincter to just naturally relax. But in a patient with Hirschsprung disease, it cleanly, definitively proves that the automatic relaxation reflex is completely broken. The external sphincter might do its job and contract normally, but that internal sphincter just stays rigidly closed.
But here's the catch. Manometry and enemas, they're really only highly suggestive. The absolute gold standard for diagnosis requires a full thickness or suction rectal biopsy. We've got to physically obtain that tissue, get it under a microscope, and find the undeniable histologic evidence confirming the absolute absence of those ganglion cells.
Okay, on to section 3, treatment options. Let's talk surgical interventions.
Look, medical therapy just isn't going to fix a gut that's literally missing its nerve cells, right? The only true fix is surgery. The primary surgical goal is the physical removal of that defective signalless highway. By cutting out the aganglionic portion, surgeons relieve the obstruction, restore normal motility to the digestive tract, and, crucially, preserve the function of the external anal sphincter so the child maintains continence.
To pull this off, surgeons use some incredibly highly specialized techniques. The heavy hitters are pull-through procedures, like the transanal SOWAVE endorectal pull-through, the Swenson procedure, or the Duhamel procedure. Take the SOWAVE procedure, for instance. The end of the normal working bowel is literally pulled down right through a muscular sleeve of the rectum, right after the defective mucosa has been completely stripped away. And for extremely short-segment disease, a simpler operation called an anorectal myomectomy might be all that's needed.
Now, if there's one thing you take away from this, it's that time is tissue. Catching this diagnosis early is an absolute game changer. If you identify it in the neonatal period, before the proximal bowel gets incredibly distended and damaged, surgeons can often perform a primary pull-through as a single one-stage procedure. This is huge because it completely eliminates the need for a temporary colostomy, sparing the infant from a whole extra major surgery and a stoma bag.
And finally, Section 4, Complications. We really need to talk about managing the dangerous risks.
Without a doubt, the most terrifying complication we face with Hirschsprung disease is enterocolitis. This is a severe, widespread, and potentially life-threatening inflammation of the colon and intestines. It happens because that prolonged mechanical bowel obstruction builds up immense internal pressure, which leads to ischemia, a dangerous lack of blood flow, and massive bacterial overgrowth. It is a direct, deadly result of that untreated physiological traffic jam.
Because of this, caregivers and clinicians have absolutely got to be hyper-vigilant for the red alert signs. Imagine an infant who normally struggles with extreme constipation suddenly developing explosive watery diarrhea along with a fever. If they appear significantly ill, lethargic, or unresponsive, this is an absolute medical emergency. There's no waiting around. It requires immediate, aggressive intervention, serious fluid resuscitation, and antibiotics.
Which brings us to our final thought for this explainer. Recognizing a mechanical gut failure early literally changes everything. It prevents massive bowel distension, eliminates the need for colostomies, and averts fatal enterocolitis. So, how do we ensure that those crucial first 48 hours are never overlooked? How can we better empower parents and frontline caregivers to realize that a missing diaper change isn't just a minor inconvenience, but a critical red flag demanding immediate investigation? It's a question that could absolutely save lives. Thanks for joining me on this explainer, and keep asking those vital questions.